We'll just go on to the last presentation, which is by Dr. Kaushik Murali, which is a keynote address on myopia. So he'll be talking on childhood myopia management.
Thank you, Dr. Rohit. Indeed, it's an honor to present in front of Dr. Pradeep, Dr. Suma, and Dr. Rohit, and many seniors and colleagues here. I'm here to talk about something that probably affects every one of us in this room. How do you manage childhood myopia? What is it that we know? And what is it we actually think we know and we are not too clear about? So to start off, myopia today has been defined. We've accepted the definition of the IMI, which says that it's a spherical equivalent of more than 0.5 diopters when ocular accommodation is relaxed. So essentially it needs to be a cycloplegic refraction that is done. How does it matter? We know it's a significant public health problem. There have been extrapolations that by 2050 almost half our population is likely to be myopic. There is significant vision loss. A variety of ocular structures get affected, and you do end up having a number of ocular conditions secondary to advanced myopia. Do we know why it happens? Well, again, there has been this nature versus nurture debate that has been ongoing for a very long time. Parental refraction has been related to myopia progression and changes in axial length. Various genetic factors have been studied. The COMET study and all of them showed a kind of correlation with both parents being myopic, and significantly it impacted. But by and large, what we have seen is that close work again has been attributed. But today probably we believe that it's a mix of both the parental myopia as well as the habits of the child, of pretty much the time that they're spending indoors, that probably kind of correlates and gives you some kind of an indication of what is happening. Studies have shown that children who are more academically predisposed spend a lot of time in more academically centered institution with more near work. Probably there is more myopia that is seen in them. Is it a cause effect? It is just a coincidental finding. We really don't know. The intensity of near work has been blamed. So today we end up telling children to take frequent breaks whenever they're doing near work. How much does it help the child? Again, we are not very clear about it. At least this is an intervention where we're helping them lead an active lifestyle, and that may possibly help. What we definitely know is that undercorrecting myopia does not help in slowing down progression. We definitely know that it results in educational delays, and we do know that a lot of children probably have a risk of bullying or ostracism. I'll come to this part a little later because we found some very interesting findings. So again, what we know is that unless there's no clear inhibition of slowing down from undercorrection, this definitely should not be recommended as a first choice of intervention when we know that there are much better alternatives today available to slow down the rate of myopia progression. So that is something that we clearly know. Again, do RGP lenses work? Again, bifocals have been tried. RGPs, again, we know do not really slow down progression. When you give a bifocal, this is a child at the bottom who's reading with a bifocal. What you slowly notice is she slowly started moving her head down, and she continues to see to the top part that is clear. The kid on top actually moves the book up. So most children, when they're able to see clearly on top, it defies logic to say that why are they going to see through a bifocal near ad, which is going to affect their vision. So we've not been great fans of using this as a treatment of choice. And although there are a few publications, read the literature through the lines, you see that there was a lot of bias in terms of who they enrolled and what they analyzed. So again, using bifocals today probably not a very great idea. Peripheral defocus has again come back into vogue. Orthokeratology and the DIMS lenses kind of work on this phenomenon. We know that the peripheral hyperopic defocus encourages growth and myopia, and the peripheral myopic defocus discourages eye growth. So the orthokeratology lenses are supposed to prevent this by changing the way the surface of the cornea is. Again, you need to understand how the technology works. There are two types of lenses. You have the cornea refractive therapy lenses, which have three curves. So they don't really kind of modify. There have been studies that have looked at it saying that the peripheral flattening of the defocus isn't as great in them as with the vision shaping treatment lenses. We have about 3 ortho-K lenses currently available available in India, the Euclid, the Breathocorrect, and the GOV lenses. Of this, the Euclid lenses are the one which follow under the VST kind of a pattern. So if at all you have a choice, it's good to look at the Euclid. Problem with the Euclid is they don't give you trial lenses. So unless your parents are motivated, it's crazily expensive. It becomes a little kind of dicey in terms of what do you do. The DIMS lenses from the Hoya and Zeiss are available. Of this, when you again read through, probably the ones that are being marketed by Hoya in India work better. This is actually a blank lens. You can see those little clear area in the center through which the child sees, and you have those eyelids. The claim is that it doesn't really affect the quality of life, and physical activities are not curtailed. We don't have too much of experience with these lenses. Again, the long-term study that has recently been published shows significant slowing, and also it shows a much lesser rebound effect. Drugs have become the mainstay. We've been using atropine. The ATOM study has shown effectiveness of atropine in slowing down myopia progression. This has been validated pretty much from across the world. We today have looked at 0.01% atropine. This was a study that we published before the commercial applications were available. We showed it was safe with very minimal kind of side effect. Why this is important? You will find a segment of children who will not be responders, or who will still continue to progress. So you may need to mix up a higher concentration, and you should not be wary about it. The recent LAMP study has shown that 0.05% is good. What we know is our experience of the last 10 years, that in 10 years or in that kind of a time frame, there are no real side effect. What will happen after 50, 60 years, we have no clue, because we don't know where atropine works. Various theories are there. So today there is a choice of also playing around and seeing whether you want to use 0.01% twice a day. We have a small cohort that we are following up. Yesterday, Dr. Jitendra also presented his paper where he's shown that about 1/3 of children on twice a day 0.01% in the non-responder category actually have a slowing down of the myopia progression. So this is our data set that we've been following up now. We have almost about 600 odd children. You see two curious things. One is, of course, you see that the spherical equivalent doesn't change, but the axial length again seems to slow down significantly, but it doesn't correlate. So what are you taught when you do a scan? 1 millimeter or a 0.1 millimeter, 3 diopters of refractive error. You don't see that in these myopes. So again, what is it that is happening with atropine, where there is an axial length slowing down, but again, it doesn't seem to correlate with the refractive error? We need to pull up data. I think Dr. Rohit has started doing that, asking us to measure a lot of parameters. Hopefully, we will have some of these answers down the line. COVID has put children indoors. Again, is it the indoor work? Is it them not being in sunlight? We don't know. Again, whole lot of studies that have come out. We again have shown that children who spend more than 2 hours outdoors, there seems to be a significant slowing, especially where there's a family history of myopia. How does it work? Again, various theories abound. We don't know the intensity. Typically, parents ask us, should I send them in the morning, afternoon, evening? We say just kick them out for 90 minutes. It somehow seems to work. Theory is that dopamine works. If dopamine works, the biggest kick of dopamine the kid would get is playing his video games. Then why doesn't that slow down myopia? So we really don't know how a lot of these things work. The last thing, again, we're finding correlations is with vitamin D levels. Again, correcting vitamin D levels seems to magically somehow contribute to slowing down of the myopia progression. Again, no idea how it works, but it seems to work. We find almost 90% of children you test are vitamin D deficient. Is there a ethnic predisposition that we are not able to absorb vitamin D? We don't know. Again, we'll have to look at it. My last slide is about the mental effect. So we keep believing that there's a huge trauma. We've studied parents. We have a team of psychologists with us. They've spoken to parents. Almost 87% of them find it difficult to manage screen time. 82% of them are anxious, and 75% of them, almost 3/4, are guilty that their child developed myopia. So there is a lot of time you need to spend with the parents and actually take away the guilt from them. Children, surprisingly, we found almost 95% of them are comfortable wearing glasses. The premise is that, oh, they'll get bullied, they won't be compliant. If they can see better, you refracted them, there's no reason why they will not wear it. But a lot of these children post-COVID are now finding it difficult to be weaned off the screen. So that is our new challenge now in how do you actually get them off these devices and playing outdoors all over again. So there are certain things we know, but there are many things we still don't know. I think it is critical for all of us in this room to look for those answers. Thank you so much for your patient hearing.
Thank you.